Our next speaker is going to be Elizabeth Herrera, who you guys have already met. There you go. Awesome.
Okay, thank you, Gary. You rock. I'm going to be talking about mitral regurgitation, which is actually at a frequency of about 2% of the population, the most common valvular disease in the Western world. And what I want you to get from this lecture is to realize that there are two different causes of mitral regurgitation, and they're very different from each other. One is primary, that affects the leaflets in the chordae, and the other one is secondary, which involves the ventricle and the annulus. So it's also been called primary mitral regurgitation has also been called degenerative, and secondary mitral regurgitation, meaning it's secondary to some other cause, is also called functional. So it took me a while to figure this out, but that's the nomenclature. So primary or degenerative mitral regurgitation can be due to a few things. One is myxomatous degeneration, which is basically fibroelastic disease. It's kind of on a spectrum like autism. So you got the P2 flail here, and then you got the Barlow's on the other side. So you have the P2 is maybe the Asperger's, and the Barlow's is like the nonverbal. They're huge, huge valves with annulus. Normally is like diameter is 3 centimeters. Barlow's is like 5 or 6. Also, endocarditis can cause primary MR and rheumatic heart disease as well. Secondary MR is due to either ischemic or non-ischemic left ventricular dysfunction. So the Carpentier classification has been what everyone uses to evaluate the cause of MR. So class 1 would be a normal valve. Class 2 would be excessive motion of one leaflet. So that would be the prolapse or flail. Class 3A is restricted motion of the leaflets, both in systole and diastole, which would be due to rheumatic disease. Class 3B is restricted motion during systole, which would be due to ischemic disease. So there are several ways that you can evaluate the severity of MR. You can use color flow Doppler, pulse wave Doppler, or continuous wave Doppler, but it's important to remember that MR is dynamic. So this is how we can evaluate MR by color flow Doppler. There's various ways that you can do it. You can trace the jet area and compare it to the area of the left atrium. You can use a vena contracta. You can use the PISA, which is a proximal isovelocity surface area, using the ERO for effective regurgitant orifice. There is this, it's important to mention the Coanda effect, which is a fluid dynamic principle where a jet tends to stay attached to a convex surface. In this case, it's the left atrial wall. These can be very eccentric jets and difficult to quantify. They are usually very high velocity, and as Dr. Tippett was saying, echo is not the only way you can evaluate MR. Use other ways like CMRI can be more sensitive. So you can also use pulse wave Doppler. Basically, we went over before that the only physiologic time that blood flow goes backwards into the pulmonary veins is during atrial contraction. Well, if you have severe MR and the jet happens to be directed to either the left or the right pulmonary vein, you can get blood flow going in the reverse direction during ventricular systole, which you can see in the top picture, which is called systolic flow reversal. Also, pulse wave Doppler, you can look at the backwards direction. So that below the baseline is ventricular inflow, mitral inflow, and then above the baseline is the mitral regurgitation. And these regurgitant jets do not obey the laws of interventricular relaxation and interventricular isovolemic relaxation time and isovolemic contraction time. They don't obey that. They just go whenever they want to go. So, so that's the time that Dr. Kosarik was talking to you about the RV. So basically, it's the whole time that the ventricle is contracting that the regurgitant jet is happening. And so these are the velocities of regurgitant jets, and not to be confused with the inflow velocities. Okay, so the velocities on pulse wave Doppler don't tell you the amount of regurgitation. They only tell you about the force of ventricular contraction, and that's dPdt. And so, like we said, timing is not limited by isovolemic contraction or relaxation. Tricuspid regurgitation in the presence of a functioning good ventricle is going to be about 3 meters per second. Pulmonary, 2 meters per second. Mitral regurgitation can be over 4 to 5 meters per second, and aortic regurgitation greater than 3. So this is a little bit about the grading of mitral regurgitation. We usually say mild, moderate, and severe. This is different ways of doing it using jet velocity, vena contracta, and also looking at supportive signs for, you know, what you think could make this something chronic or something acute. And always remember that MR is dynamic, and it's influenced by the 4 components of forward flow, which are preload, afterload, heart rate, and contractility, right? So you can make the MR by just manipulating these 4 variables. You can make, sometimes you can make moderate MR mild, or mild to be moderate. So evaluation of MR location, you can use either 2D or 3D TEE in the operating room. And you can see exactly what Dr. Tippett was talking about, and the relationship between the mitral valve and the aortic valve and the aortomitral curtain. So first is the a normal valve, a normal mitral valve. Second is an A2 flail. And third is a P2 flail. I'm going to see if I can play it. Well, actually, you can see it pretty well. It stopped at the right place. So A2 flail is pretty easy to see right here. You can sometimes, it's hard to see when it's moving. So you got to stop it at the right spot. Okay, just slow it down. And you can also slow things down on your echo machine. But if you just stop it, you know, slow it down, then you can see things. So that's, I stopped it, and I say, okay, yeah, it's an A2 flail. The chordae are pointing toward the posterior leaflet. This is kind of rotated around, but this is a P2 and P3 flail. The chordae are pointing towards the anterior leaflet. And TEE has, the 3D TEE has shown us things that we never really knew before. Like we couldn't see before. I mean, basically, this is a cleft posterior leaflet of the mitral valve. This patient did have MR, but I never saw it on 2D. So 3D can give you some more information that we didn't know before. So that's a posterior cleft leaflet. But 3D TEE doesn't show you everything. This is a patient who has some echogenic material floating around in the LV. And that ended up being a ruptured papillary muscle, which you can only see by 2D. So here's a patient with a midesophageal four-chamber and midesophageal commissural with a posterior flail leaflet with a large annulus. So that's a P1, P2 flail with a dilated annulus. And always look at the non-color first so you can see exactly what's happening. And with the excessive motion, the direction of the jet is going to be going in the opposite direction of the affected leaflets. So you can predict that this is a posterior leaflet problem. The jet is going to be directed anteriorly. This is a P2 flail. So Dr. Tippett was talking about the posterior leaflet being more vulnerable to dilation and strain, and so we actually proved that At Methodist, we are looking at post-processing strain on imaging for mitral valve leaflets, and you can see that here's the posterior leaflet. Well, anyway, the red. So this is strain. The highest amount of strain is at P2. So it's not surprising that P2 is usually the leaflet that's affected. And this is our post-processing, what we use with TomTech. And you can see this is how we calculate, or we use a program to let us figure out how much strain is on these leaflets pre and post repair. And this is out of Methodist. We looked at the effect of valve repair on valve leaflet strain, and the overall global strain pre-repair and post-repair is lower. The global strain is in the pink. The posterior leaflet strain is in the green, and that really decreased after mitral valve repair. So you knew this was coming, the vortex. So this is the effect of dilated non-ischemic cardiomyopathy on the flow patterns during diastole and systole with interventricular vortex. So at the right is the normal heart, and you can see that when these go from 1, 2, 3, 4, 5, 6 in that order, you can see blood flow. This is the velocity of blood flow right here. The highest velocity being in the blue to purple range. So when the blood flow is coming in at figure 1 in the normal heart, where the vortex forms, and then blood flow coming out at systole into the LVOT, that's very high velocity flow. So looking at patients with dilated non-ischemic cardiomyopathy, the shape, or the size and the location of the vortex is changed, so you do not get the same efficiency of LV contraction and of blood flow moving out of the heart. And this is a patient who does have non-ischemic dilated cardiomyopathy, and you can see that the leaflets, they don't even come together. For some reason, it's not doing that. Okay, and this is the same patient, and you can see it's stopping right here. The leaflets don't come together. Now, this is a cause of ischemic mitral regurgitation. You can see the outward bulging of the inferior base of the left ventricle. And what you typically see on the 3D is the location of P3 and A3 is unable to coapt because this papillary muscle is being pulled out of the from this normal location. And this is for the, this is very important for when you have a patient, you take them to surgery for a CAB, and you see MR. So one thing you do first is try to determine whether it is primary versus secondary MR. And if it is secondary MR, is it moderate or is it severe? Because right now, as of 2017, the AHA and ACC guidelines of management for patients with valvular heart disease says that if you repair ischemic MR that's moderate, it's only of its usefulness is uncertain. And the American Association for Thoracic Surgery, AATS, says that it may be considered, but it's not it's not strongly recommended by either the cardiologist or the surgeons to actually repair moderate ischemic mitral regurgitation at the time of CAB. So there's been many, the reasons why they came up with this is because there's many prospective and retrospective studies, and they found no compelling evidence to repair it at the time of CAB. So the reason why is because when you look at these patients down the road, there's no survival advantage for surgical correction. So that these patients, you try to, obviously treat them medically because MR is dynamic. In the operating room, you can manipulate their physiology, hopefully. And also resynchronization therapy is first line for these patients. So just about the vortex formation for patients who have prostheses in their mitral annulus, you can tell that there are all sorts of weird stuff happens between patients who have porcine bioprosthesis or any kind of bioprosthesis, mechanical valve replacement in the anti-anatomic or anatomical position, and the only way you can try to maintain normal flow dynamics is to actually repair the valve. And I think Dr. Laurie showed you yesterday when he showed you when you could put any kind of prosthesis in the mitral position. The direction of flow is not aimed toward the apex anymore. It's aimed in a different direction toward the septum. I'm sure he showed you that yesterday. So basically, the only way to maintain the normal flow in the left ventricle is to actually repair the valve. But not all repairs are the same. So this is a patient who came in from an outside hospital who had a mitral valve repair, who had a rigid ring. And you can see these interrupted sutures. And the annulus, look at this annulus. It's not moving at all. And there's something like right here that we thought was could be leaflet. So this patient had severe mitral regurgitation, and we did our own vector flow mapping here. Sorry about the bovie interference, but you can imagine what this MR does to the formation of vortices in the left atrium. So here is a patient. We did a reduced sternotomy, took out the rigid ring. Dr. Laurie put in a flexible ring annuloplasty. You can't see the sutures because he does a running suture. And we restored the normal annular dynamics of this patient. You can see the aortic curtain bulging in, which is what happens when you have systole, okay, because the LVOT is dilating. And you can see normal restoration of the vortical laminar flow coming into the left ventricle, mitral valve closing, there's no regurgitant flow, and laminar flow coming out of the aorta. So conclusions. Patients presenting with primary versus secondary MR are completely different and should be treated differently. And MR can be quantified by various methods, and physiology can be altered to increase or decrease the severity. And thank you very much.